Okay, so we are here today with Dr. Sidney Kadish, and it's an October day in 2013, and we're going to begin our interview. What first drew you to medicine?
I grew up in my father's drugstore, and my father's drugstore was your typical American drugstore where we really took care of the customer. We called them customers in those days. And we tried to get them the things they needed for their health. And I saw, as a 12-year-old kid, certain new medical miracles like cortisone and antibiotics that were the beginnings of, semi-synthetic penicillins. And I looked around that drugstore and I said, I want to learn more about this, and I want to be able to call the druggist with my prescriptions, not fill the prescriptions that the doctor was calling in.
When was this?
In the 50s. In the 50s and late 50s, yeah.
Mm-hmm. And so you went to college?
I went to college with the idea that I was going to be pre-med. And I did do a pre-med program. I took a little sidetrack because I took a Shakespeare survey course, and I fell head over heels in love with it. And for a second I asked myself, do you want to jettison the medical career and go in and be an English professor? And then I said, no. You want to be in a service profession and take care of people and use science to bring wonder and cure to people.
Mm-hmm. And where did you go to college?
Columbia in New York.
Mm-hmm. And then you went on to medical school?
I went to the U of Chicago, where our president was a law professor. I didn't know him then.
This is President Obama.
Right.
Uh-huh. And
but when President Obama said that he was a community organizer, the people I saw as a medical student were the members of that community.
The people he organized. And this was back in the 1960s?
Right. I was in medical school between 63 and 67.
Mm-hmm. And what sort of experience did you have in medical school? What were the courses like? What was the workload like?
I think medical school is the same everywhere. We had 2 very rigorous years of the pre-clinical studies. They were very hard, and I always like to tell the story that the first Christmas that I went back to New Jersey and I said to my widowed mother, I said, boy, that was the hardest school I've ever had. And she said, well, try something else. But I didn't want to try something else. I stuck with it. It got a lot better once we got into clinical rotations and we began to see taking shape the notion, the possibility that I could become a healer.
Mm-hmm.
And it just got better and better. And then, of course, I was thrust into internship where I discovered I knew nothing. Mm-hmm. Which is most interns' experience.
And this was during the Vietnam years?
It was. That is correct.
And was that effect around you in any way with your schooling and with the protests and the various concerns regarding the military?
I think it was, I would have to say, it was fairly peripheral.
Mm-hmm.
At one point, the class invited Paul Dudley White, the famous cardiologist, President Eisenhower's cardiologist, to come and talk to us. And we thought he would talk to us about taking a stand against the war and so on. And he admonished the class to finish getting their degrees and learning how to be doctors, and then they could be useful citizens.
Mm-hmm. And when did you decide to go into radiology?
Well, the story with me, I did a lot of zigzagging. I was originally very interested in urology. I was very inspired by the chief of urology at the U of Chicago. And as I began to learn about urology training, I discovered to my horror that that would require 2 years of general surgical training. And the more I thought about it, the more I realized that life was going to be too brief for me to offer up 2 years of general surgical training. So I nixed that. And the next thing on my list was radiology. And I eventually applied into a radiology training program, and it turned out that it was at the Massachusetts General Hospital that I was accepted, which brought me to New England, which was very fortuitous because I've again fallen in love with New England, and I've stayed in New England ever since my training was finished.
And what sorts of things attracted you to radiology?
Oh, I loved the idea that the images had so much meaning if you knew how to interpret them. The problem that I had is that the training programs in my day, or at least when I began, involved diagnostic radiology and radiation therapy. And I love diagnostic radiology, but in those days, diagnostic radiology training involved an awful lot of upper GIs and barium enemas, whereas the radiation therapy was a matter of curing people or treating people, and I loved my patient contact. And in 1970, I decided that I would not pursue diagnostic radiology further, and I told my program director that I only wanted to stay with radiation therapy. And it turned out I was the first trainee they ever had at the Massachusetts General Hospital who elected that way.
And your training completed, and then what was your next step?
After my training, I had a military obligation, and I had applied for the Berry Plan, and I was granted the Berry Plan in radiation oncology. My military occupational specialty was radiation oncology, and to my delight, I was deployed to the Tripler Army Medical Center in Honolulu to do 2 years.
And how did you find your military service?
My military service was like a dream. It was wonderful. The military part of it was that I knew what I would be wearing every day, which was the khaki uniform of the U.S. Army Medical Corps in warm weather. But I was really functioning as a professional, and the hospital was full of similar type Berry planners, doctors who just finished their training. They're very anxious to practice their art and skill, and professionally it was a very inspiring and lovely experience. And I don't have to say what it was like extra professionally.
So the Berry Plan, can you tell us a little bit more about what that entailed?
I believe it was a Senator Berry who put forth legislation a few years before which allowed people who were accepted in the program to complete their residency training so that they would enter the service as specialists. And so, as I say, we had a lot of those kinds of people in the hospital.
Did it involve financing your education at all?
No,
but it involved a deferment so that you could complete your education.
Precisely.
Exactly. Okay, great. And after the military training, what was your next move?
When I finished my training and my military obligation, I had been married, and my father-in-law had died in the last year that I was in Hawaii, and my wife was from New Bedford, and she wanted to be close to her widowed mother, so I took a position at the Rhode Island Hospital, and we lived in Barrington, Rhode Island, and that was about 20 minutes from where my mother-in-law lived in New Bedford.
Hmm. And how long were you there?
I was at the Rhode Island for about a year and a half.
Hmm.
What happened was, during this period, there was a effort at St. Vincent Hospital to revamp and modernize the cancer program, or to develop a cancer program. The status of radiation therapy in Worcester in the early 70s was that there was no full-time department or full-time practitioners, but it was a sideline of radiology departments with cobalt machines kind of stuck in the back of the department. I was offered an opportunity to develop a new department with linear accelerators and treatment planning and all of the features that we associate with university-style radiation therapy. And my old junior staff, Murray Janawar, who was the chief of radiology at St. Vincent and did a terrific job of modernizing that effort, invited me to lead this new department and to develop it. And I took it, and it turned out that we very quickly got very busy and we needed a second machine, and we, I think, ended up making good on that proposition that people, to get good radiation therapy, don't have to go into Boston, but they can have it in Worcester.
And so during the 60s when you began your training, and then 70s when you were in your early career, what sorts of patients did you see? What sorts of cancers did you treat? What sort of cure rates and technology and side effects did you encounter?
Well, one of the major type of patient that I saw was the breast cancer patient, and during this period of my career, we saw the evolution of the care of the breast cancer patient from the Halsted mastectomy to lumpectomy and radiation. And I think in the beginning of the 80s, this was accepted from the National Cancer Institute as the treatment of choice. It was very interesting to work with surgical colleagues. Some of them accepted this modification. They believed the data that showed that a more conservative approach would allow women to retain their anatomy and their breasts, and they accepted it cheerfully. Others were kicking and screaming because this was such a basic and fundamental teaching of surgical training years ago. But it was very, very interesting to be a player in that evolution.
Mm-hmm.
Now that's only breast cancer, and of course there were changes in other disease categories that affect someone in my specialty. For instance, head and neck cancer, we saw, which was a national or even an international trend, reduction in mutilating surgery and more of a reliance on the use of radiation, including the use of radiation with chemotherapy.
Mm-hmm.
And during the time that I was brought into St. Vincent, there were medical oncologists who brought chemotherapy in so that we had all the pieces to make a good and effective cancer program.
How did the technology evolve over this period of time?
I think, to summarize, the technology, well, it began like this. You know, Dr. Röntgen discovered X-rays in 1895, and X-ray machines were used for treatment of cancer, particularly things like skin cancer, for the first few decades of the 20th century. At the same time, Madame Curie discovered radium, and radium was encapsulated and it was inserted into body cavities, particularly for gynecologic malignancies, very effectively in the beginnings of the 20th century. At the time of World War II, some terrific things happened that seemed to be byproducts of the war effort. The isotope cobalt-60 was cobalt-59. We all know cobalt-59 from those beautiful blue glasses that people have. But if you put that cobalt-59 in an atomic pile, it becomes cobalt-60, and that gave off a beam that was more deeply penetrating and opened the so-called supervoltage era. Not long after that, there were offshoots of the sonar technology that was useful to detect submarines in World War II that were incorporated into linear accelerators, which were developed in California by the Varian brothers. And these miniaturized linear accelerators were re-engineered to fit into community hospitals. And they were affordable, and they produced an even better beam than the cobalt machine. Mm-hmm. But the real transformation in radiation therapy occurred with the development of the computer age. And when I first left the Massachusetts General Hospital, we had no computerized treatment planning because that technology was not yet developed. As you probably know, today we can take a CAT scan of a patient, and slice by slice we can draw what we want to treat and exclude what we don't want to treat. And by virtue of advanced and sophisticated computer technology, we can restrict where the beam goes and treat much less normal tissue unnecessarily.
So early on, you were basically sitting there with a pencil and paper and trying to calculate dosages, or?
No, we've always had the help of physicists to calculate doses, but in the old days we used fairly generous fields because we weren't really that certain. We had to eyeball it, and we couldn't tell where the beams were going, so we had anterior and posterior films, and we had x-rays that would see where these fields were going. Today, and it really goes beyond the scope of this interview, but today the engineering and the precision is so sophisticated that I almost can't take it into my head, because we have something now called intensity modulated radiation therapy, where beams are actually computer driven into little beamlets, and these beamlets come on and off, and they come and they go, and only a computer could devise this. As a radiation oncologist, and I see my patients every week, I know that the radiation is getting to the places we want it to get to, because I have to see the patients, and I can tell from examining them that it is working out as it's supposed to be. But I can't take it in conceptually so easily anymore.
And has this enabled you to treat cancers that previously were outside the realm of radiation oncology?
Well, I would say the field has undergone dramatic change. If you really want to know about that, you have to read that book, The Empire the Emperor of All Maladies by Mukherjee, but we've had the development of chemotherapy that has added so much to our armamentarium of treating cancer. We've had great progress in surgery and reducing the morbidity of surgery and increasing the safety of surgery. So in other words, it's a symphony orchestra. It's not one instrument section, and we're all working together, but I think there have been advances in all of the major treatment categories.
Mm-hmm. And what sort of cure rates would you expect for a couple of examples, let's say back in the early 70s with radiation oncology? Can you compare those to today, for example, and what cure rates you're getting at this time?
Well, I'll give you an illustration, but it's very hard to answer the question because, as you know, there were many, many malignant disease sites, and each one of them is staged. Okay? So the earliest stage in larynx cancer, even in the old days, was about 90%, because there's not very much tissue between the outside and the larynx, and even old-fashioned equipment was able to handle that. Today, lung cancer, which lung cancer presents always a real problem because we know what causes it. It's due to smoking, and everybody throws up their hands and says, socially, we can't mandate that people stop smoking. We can't forbid tobacco in our society. We just have forces that won't allow us to do that. Well, one of the latest things that's happened, one of the most exciting things, is for small coin lesions that are biopsy proven, we don't have to have those patients have their chests open up anymore because we're using a program called stereotactic body radiation therapy, and they get about 5,000 or 6,000 centigrade in 1,000 centigrade treatments once a week, and those lesions are, the cure rate is about 85%, and the morbidity is almost zero. It's fantastic. That's an example of a major advance in a little niche type of subset of patients with lung cancer. Now, you know, when you look over the whole array of malignant disease, so much of this has to do, first and foremost, with our ability to screen and find it. And if we have a pap smear and we can find cervix cancer early and we can get our people to come in and have that test, we're going to be in good shape, and we're going to be able to cure these people easily because it's early stage. There have been some advances in terms of that, and I think we're going to be on the brink of even more advances, particularly when we are into more genetic, so we can identify who we really need to screen for certain things.
And with regard to side effects, what sorts of side effects had you encountered and do you encounter at this time with regard to radiation therapy?
Okay, so I said that what's happened in the last decade or so, maybe the last 2 decades, particularly with the computer age and our computerized treatment planning, it's not so much that we're curing more people, but we are leaving them with less morbidity. And that's a real plus. I've had patients in my career say, oh, you know, my aunt had radiation, she was burnt to a crisp, you know, and things like that. And we have to say, well, yes, in the old days that's what happened, but we really ought to be able to prevent that. and we do
Mhm.
in today's modern treatment.
So basically with the multiple beams, the moving, the different types of radiation that have deeper penetrance and everything, the side effects have diminished over your career.
Right. If you design the treatment cleverly,
Mm-hmm.
you can really reduce the morbidity.
Mm-hmm.
Yes.
And what sorts of, now your practice has always been in the hospital, and so you have a referral practice, you get patients who are sent to you by people who've gotten their diagnosis,
Right.
and you've practiced in Rhode Island, you practiced at St. Vincent's, and then more recently you've been over at university?
I left St. Vincent at the end of 1999, and I spent 2 years at the Leahy Clinic, and then I came back and signed on at UMass.
Okay. And so these are different environments. Do you have any sense with regard to healthcare delivery and, you know, the various differences between those models?
Well, I can say to you that I think, for instance, about the difference between what happened at St. Vincent and what happens now at UMass. UMass is a larger institution. We have a lot more doctors out there. I think there are a lot of things that are similar, though.
Mm-hmm.
We have, for instance, today we have a lot of subspecialization. At UMass these days, I'm going to the GI tumor board, which comes every week. I go to a head and neck cancer tumor board. I moderate that. That's monthly. And I go to a cutaneous malignancy tumor board every other week. But I'm not treating breast cancer or prostate cancer or gynecologic cancer like I used to do, because today that's the trend, to subspecialize.
Mm-hmm. Okay. And with regard to the various changes in healthcare delivery, you were in medical school around the time that Medicare and Medicaid were put into place in the mid-60s.
Right.
And then later you practiced at the very beginning of the HMO movement, and you were in Worcester at the time that the first HMO in Worcester, Fallon Community Health Plan, started, and have been there as there have been a transition between people who've had to pay for their health care out of pocket and then had limited insurance coverage and then more widespread insurance coverage. Have you noticed that in your practice at all? Has that made a difference with regard to the stages at which you see patients with their disease?
Yes, I would say when I was at St. Vincent, I saw an enormous number of women who had screening mammograms, who had disease found at an early stage. And while I have never, tabulated that, I have no doubt that many women, hundreds of women, were cured and were able to preserve their anatomy by virtue of those screening efforts.
Mm-hmm. And over the past 5 or 10 years, when there's been more widespread insurance in Massachusetts, have you noticed any differences? Do you feel that it has been a noticeable change?
My real sense is that the type of middle-class people who belonged to the Fallon Clinic back in the 90s and the 80s were the kind of people who responded to the notion of screening, and they had good internists and primary care physicians who had rigid schedules about screening, and people got their colonoscopies, and people got their pap smears and their mammograms, and we ended up seeing early disease, which was curable disease.
Mm-hmm.
Now, where I am right now, we have a mixed bag. We have all kinds of different people. So it's not all middle-class people, it's not all welfare people, it's not all Medicaid people, it's very mixed. You know that there are members members of our society who don't respond to the call to go get screened, but they'll come once they have a serious problem, and they don't do as well.
Okay. So what I'm hearing you say is the availability of insurance may make some difference, but the insurance alone doesn't solve the problem of early access, since just for one reason or another there are many people who may not avail themselves of that. Now, you also have practiced during a time in which there have been just revolutions in the technology that you use. Does this put pressure from a cost point of view on your department?
Oh, yes.
Can you talk about that a
Well,
little?
radiation oncology equipment is expensive equipment. I put machines into St. Vincent. They were about $1 million a piece. Now they're $3 million. It's very expensive. It's very costly.
Mm-hmm.
The American public wants to have access to things like radiation therapy service, and the notion is that no matter who you are, you ought to be able to be within 30 minutes of a center that you can have your treatment. That's actually a wonderful goal.
Mm-hmm.
And when I was at St. Vincent, I had the notion that we have people in the North County, Leominster and Wichita and Orange and places like that, who in order to get a reasonable course of radiation would have to travel for more than 30 minutes and sometimes even more than an hour. And at the time I was active in the American Cancer Society, and we proposed the notion of a lodge, a Hope Lodge, that people could stay.
Mm-hmm.
And I'm proud to say that that came about, and we do have that as a resource in Worcester if we have somebody who's far away. What's more, my boss, Dr. Fitzgerald, worked very hard to develop a radiation therapy service, which is a satellite of the UMass program up at Burbank Hospital in Fitchburg now.
Mm-hmm. So the larger groups have enabled outreach that may not have otherwise been possible.
Right.
Okay, excellent. And what sorts of things right now are happening within your field that you feel are exciting?
Well, I already talked to you about stereotactic body radiation therapy. We're also doing, let's say, like a patient has brain metastasis, and we treat the brain with radiation because we are concerned that there are going to be microscopic disease elsewhere in the brain, not just what shows up on the MRI.
Mm-hmm.
And then when we're done with our treatment, if we see there's residual disease, we can boost that residual disease with something called stereotactic radiosurgery,
Mm-hmm.
where something 3 cm or less can receive a single fraction or 3 fractions and have that basically vaporized.
Mm-hmm.
It's wonderful.
Mm-hmm.
And it, again, spares the patient having to undergo surgery.
Mm-hmm.
It's all because we have accuracy. Today we have the ability to take a PET scan, which shows us where the disease is, and we can fuse it with our treatment planning capacity as a CAT scan slices,
Mm-hmm.
and we can plan using the PET scan as the mechanism that's directing our beams.
Mm-hmm. Mm-hmm.
So it's terrific.
Excellent. And during your career, you've had some involvement with organized medicine, with medical groups of the like. Can you talk
Oh,
about that a
yes.
little?
Well, I should start by saying that I've been involved with the Worcester District Medical Society and the fabulous Joyce Cariglia, and I was privileged to be the president, I think in 87, I think.
Hmm.
And I was involved in the Mass Medical Society and I enjoyed my work, and particularly the District Medical Society, and I don't tire of participating. It's very nice. I love some of the people who've gone through there and now are in leadership positions, like George Abraham and Michael Hirsch. They're doing a wonderful job, and it's clear to me when I was active at the Medical Society, at the Mass Medical Society, that the Worcester District is absolutely the best. It's the best in this great Commonwealth. It's absolutely the best.
And do you feel that the trend towards larger multi-specialty groups in medicine has sort of moved physicians away from communicating with each other freely, or are they able to communicate with each other better? Is there a fellowship of physicians, or is there a fellowship of organizations?
Now you're asking me a very difficult question. In my work, I would say to you, you heard me talk about different tumor boards. And tumor boards are the way we get the different specialties together in one room. And those tumor boards all have something in common. A case is presented. We have a radiologist who really shows us the radiologic information from that patient in a professional manner. And then we have a pathologist who shows us what we're really dealing with, because so much of what we do turns on the pathology. So there's excellent communication when it's organized to be that way. And while I'm saying at UMass we do this subspecialty by subspecialty, even at St. Vincent we had a weekly tumor board where difficult cases were presented with the idea that the various cancer treatment modality representatives would lend their opinion as the cases were presented. Now, this is a very, very good outcome. I have the feeling that the way things have evolved, we're not talking about, the cancer patient gets surgery and then maybe radiation goes afterwards to clean up what's left. No, there's a genuine understanding that each player brings something to the table. The only decision is how do we work it out so the best is done for the patient. It may be that the very best is that the patient undergoes surgery, and that's all. But based on surgical findings, maybe there's a role for post-operative chemotherapy or post-operative radiation. Maybe there isn't. All these things are detailed. It depends on the disease, and it depends on the stage, and it depends on the status of the patient. Now, that's a matter of getting together to discuss patient care. In terms of getting together to discuss how we're managing, well, I'm not happy that, we have this group of doctors and then this group of doctors and there's competition and, I think where we're headed, and I'm not taking any political stance here, but where we're headed is we probably are going to be trending to reduce this dimension of competition and to just be working to deliver the health care. I think the amount of health care that we have to deliver is only growing greater, and if people are insured, they're going to seek more health care. And we all know that when people are disabled by ill health, it's terrible. It's terrible. We should have people living in health. And we all know that our lives today, people are living well into their 80s and 90s and enjoying life, and they're not disabled. And we remember our parents and our grandparents who were broken down people in their 60s. And we we want to be part of that effort. Now, how that has to be worked out, to my mind, is a headache for healthcare planners. And I've talked to healthcare planners, and it's a very frustrating work. It's much better just to be treating the patients.
Okay. Well, there are elements of your field that I think have foreshadowed what needs to be done in the rest of medicine. You bring up a number of them during this interview, including tumor boards, which are a way of bringing in multi-specialty input and teams to take care of patients and making sure there's communications and good handoffs. The other part of this is tumor registries, which you might want to mention a little bit. But that, the fact that everybody's outcome needs to be tracked is something which, at this time in the rest of medicine, is not getting as much attention as it deserves.
Well, I agree with you. Tumor registries are a way of quantifying just what we do. And the Commonwealth of Massachusetts mandates this. This is part of, what good hospitals are supposed to do. We have organizations that come by, like the American College of Surgery, and actually review cancer programs, and one of the features that they review is, do you have a viable cancer registry? What good is the cancer registry? Are people looking at the cancer? Are people evaluating how they're doing if they look at a certain disease entity? Are we giving people sufficient care so that our numbers look like the published numbers? These are important issues, and it's being done at big places.
Okay. All right. Well, we've covered a great deal here. You've had a career that has spanned an exciting transition in medicine. You've gone from a time in which, as a child, you were just seeing some of the early antibiotics and pharmaceutical treatments, into a time during your residency training and everything when there really was an awakening of the potential for radiation therapy. You were among the first in that field at Mass General, and then a career practicing during which there have been major transitions in the way cancer has been treated. So this is really remarkable. Are there any sort of final remarks that you'd like to make?
Well, I would just like to say I'm about to retire in a few months, and I've had 41 years of doing this work, and as you say, it has evolved. It evolved from a fairly crude specialty to a very sophisticated specialty. I am told that many medical students want to go into this field because it's this nice combination between direct patient care and, sophisticated equipment and machinery and so on. I've had a very satisfying career, and I feel very blessed that I could participate, that I could be given the honor and the privilege of participating in the care. And I also have spent the majority of my career in the city of Worcester, where I've worked with wonderful colleagues, and I've always had a very positive feeling about our Worcester doctors and the Worcester medical system, because I've been in both camps, and it's been very positive on both sides. It's been very positive to work with our Worcester doctors, so I feel very privileged. So thank you for this opportunity.
Well, that's wonderful. Thank you so much for giving us this interview today.